Emergency situations in children are often life-threatening if not treated quickly and effectively. Because of their developmental level, they are at a greater risk for near drowning, poisoning, and traumatic injury compared to adults. Most of the pediatric cardiopulmonary arrests result from respiratory failure or shock. Data suggests that children who have a cardiopulmonary arrest requiring resuscitative measures rarely fare well. For these reasons, the American Heart Association has defined two distinct chains of survival. The table on page 1994 presents the most recent recommendations for ratios of breaths and compressions. Many medications and treatments are used in pediatric emergencies. Most of the treatments require a physician's order, unless there is a standing order, such as in the emergency room or intensive care units. The nurse working in an area that handles pediatric emergencies should be familiar with the procedures and medications to be able to provide the best care for the child. Drugs given by this method should be followed by 5 milliliters of sterile saline and 5 consecutive multiple positive pressure ventilations to ensure the medication has been delivered. Although these drugs can be delivered in this method, it is not the preferred method of delivery. IV access would be the preferred method. When evaluating a child who presents an emergent condition, always follow the AHA's guidelines for basic life support. As a brief history is being obtained, begin the rapid cardiopulmonary assessment. Most pediatric arrests are primarily related to airway and breathing. In many circumstances, if the child's airway is properly managed and breathing is assisted, the child may not experience a full arrest requiring chest compressions. For the child receiving 100% oxygen who does not improve with repositioning, assisted ventilation with a bag valve mask will need to be started. If continued bag mask ventilation is needed, the child may require airway intubation. Nurses need to be adept in identifying the beginning stages of an emergency so they can quickly and efficiently intervene to prevent deteriorations to cardiopulmonary arrest. Infants and young children are at a greater risk for respiratory emergencies than adolescents and adults. Table 51.2 lists causes of respiratory arrest in children categorized by body systems. Tachypnea is often noted in children in respiratory distress. Hypoventilation occurs in very ill children or ones who have central respiratory depression secondary to narcotics. Periodic breathing is often seen in infants. Always evaluate and manage the airway first. If the child is not breathing, begin rescue breathing. Position the airway in a manner that promotes good airflow. If the airway is blocked by secretions, suctioning would need to be performed. However, if a cervical spine injury is a possibility, do not use the head tilt chin lift. Use only the jaw thrust technique for opening the airway, shown on the right. After establishing an open airway, look for signs of respiration. Look to see if the child's chest is rising. Listen for air escaping, and note if you feel any air coming out of the child's nose or mouth. Airway and ventilation methods are listed in more detail on page 2001. In addition, review tables on pages 2004 and 2005 related to tracheal intubation. If the child begins to deteriorate, perform a quick assessment. Auscultate the lungs for bilateral breath sounds. Suction the airway if needed. Make sure all equipment is connected and functioning correctly. If the tube is deemed dislodged, remove the tube and begin bag mask ventilation. Shock can be defined as an inability for blood flow and oxygen delivery to meet the metabolic demands of tissue. If shock is left untreated, cardiopulmonary arrest will result. Shock can be compensated or decompensated. Compensated occurs when poor perfusion exists without a drop in blood pressure. while decompensated shock includes a drop in blood pressure. It is important while caring for a child suffering from shock to not focus solely on circulatory status, because signs and symptoms of respiratory deterioration can easily be overlooked. Most commonly, children experience cardiopulmonary arrest from gradual deterioration of respiration and/or circulation. There is substantial evidence that if primary respiratory compromise or shock is identified and treated in the critically ill child, a secondary cardiac arrest can be prevented. The American Heart Association has established 3 major categories of cardiac rhythm disturbances. Bradycardia in children is most commonly sinus bradycardia. Heart rate can drop when the child is sleeping or can be associated with vagal stimulation. Sustained bradycardia is an ominous sign and should be taken seriously. Tachycardia can be caused by fever, fear, and pain. Hypoxia and hypovolemia are pathologic reasons for tachycardia in the child. There are also comparison charts on page 2011 for bradycardia and tachycardia. The most common pulseless arrest rhythms in children are asystole, or pulseless electrical activity, or PEA. Because of potentially devastating effects that drowning-related hypoxia has on the child's brain, airway intervention must be initiated immediately. Every second counts. Initial interventions are always focused on the ABCs. Usually, the child exhibits some degree of hypothermia and will require warming. Core body temperature should be raised slowly. Survival and neurologic outcome of drowning depend on early and appropriate resuscitation. The suspected poison may direct the lab and diagnostic testing. The nurse will need to give priority to the ABCs. Activated charcoal may be administered to bind to the chemical substance in the bowel. Dialysis is sometimes required to lower the level of toxin in the bloodstream. Specific treatment will be determined when the toxin is identified and poison control is contacted. The nurse will need to maintain ongoing assessment of the child due to the fact that many toxins exhibit very late effects. Young children rely on their caregivers to promote their safety. They also are not developmentally equipped to be able to recognize dangerous situations in many circumstances. The initial survey will include a brief history as the child is being assessed and life-saving measures are being instituted. Children with head injuries who have signs of shock should receive fluid volume resuscitation. All of the information can be found in Chapter 51.